Good afternoon. We're just going to wait another minute or two for people to sign on, and then we will get started. So thank you for your patience. Okay, I think we will get started. Good afternoon. My name is Mark Graham. I'm the Vice President of Program Services at Coordinated Behavioral Care. And I welcome you to our COVID Town Hall today on this beautiful spring day. And I just want to tell you a little bit about our town hall. Our town halls came about at the request of our member organizations at CBC. And we were approached by some at the end of last year who felt that their staff had questions in relation to COVID and the particular areas around COVID, and that they didn't really feel best equipped to address themselves. And so they asked if we at CBC would find some resources and an opportunity for their staff to be able to ask questions. And they suggested a town hall format. And so we were able to set this up. This is our third one. Last time around, for those who joined, we looked and focused on vaccinations. Today, our focus is a little bit more on our younger New Yorkers, children and teenagers, and their experience with COVID. And I'm delighted to be joined today by Brad Hutton, who is our subject matter expert for the day. Brad has been with in the public health field for the last 26 years, 10 years of which were at New York State Department of Health. So good afternoon, Brad. If you'd like to just maybe introduce yourselves a little bit more, we're delighted to have you.
Hi, Mark. Really looking forward to this session and glad to have been invited. So as you mentioned, I was formerly with the New York State Health Department, where I served as our Deputy Commissioner for Public Health for the last 5 years before I left in August of 2020. I actually oversaw our health department's response to the pandemic from January through August, and my background's in infectious diseases. And since starting a new chapter as a public health consultant, I've been working with Trivedi Consults on a lot of COVID reopening support issues.
Great. Thank you again for joining us today. And I think we talked last week, you had put together a few slides as a sort of reference points, but you were going to start us off by just giving us sort of an overview of really across the states and in New York State in particular of COVID cases and so what the lay of the land is currently.
Yeah, let me share my screen and go through some initial slides before we get into the discussion portion of the session here today. So I want to just start with a little situational update on our pandemic to date. First, this is a chart that shows the total number of COVID cases in the United States by day from the beginning of the pandemic to this weekend. And you can see we had an initial peak in the spring. The summer peak actually had a higher number of cases. And then this most recent peak in January, February had many more cases across the country. Fortunately now we've declined so that we're at a much lower level, but still at a level across the country of 50,000 cases per day, which is much higher than what we saw in the spring and really matching our summer peak. And so I think the message here is that while we're seeing cases decline, we're still at an unacceptable level of daily cases. Similar chart now for New York City. Obviously, we had a much greater concern here relatively to other parts of the country in the spring, which is why we see this March and April peak. We did not see that summer surge, which really occurred across much of the rest of the country. We did see this January, February 2021 surge. And again, while case counts are declining, we're still now at 3,000 to 4,000 cases per day. And I don't think that that's a level that we want to continue at. Just looking at the numbers for the pandemic to date, We're at approaching 30 million cases in the United States. That's confirmed based on a lab diagnosis. The true number is probably much higher. Over 500,000 deaths. And just to give you a sense, on a daily basis across the country, we have almost 31,000 patients hospitalized for COVID at any given time. So still quite a bit of morbidity. This is the good news slide because it shows that the number of vaccine doses that are administered each day in the United States continues to increase. And so what you're seeing here is just the typical weekly cycle, and that the numbers of doses administered on the weekends are lower than in the middle of the week. But with each week, we're delivering more and more vaccine. There was a time here early on where I think people were frustrated with the slow pace of vaccination, and that's when we were maybe in the range of 800,000 doses per day. And you can see we've grown to the point where we're much higher than 1 million doses, and even 2 million doses. And I think we'll soon be delivering 3 million doses per day, which it really speaks to the real large infrastructure of vaccine administration, which is really occurring countrywide, but especially here in New York State. I want to shift and just talk a little bit about COVID-19 in children and some of the epidemiology, because we've learned a lot over the course of the pandemic. First, I want to just show those trends of COVID cases over time by age group, because I think there's a couple interesting points here. Now, again, this is cases. You can see that the lowest incidence, so the least amount of COVID occurs in the 0 to 5-year-old population, and that's this bottom line here. And that's followed by 6 to 13-year-olds. And you can see that basically the trends over time are largely the same. When we experience surges, we experience surges predominantly in all the different age groups. But then I think it's interesting that the highest incidence, the most COVID occurs in the 18 to 24-year-old age group, followed by the 25 to 34-year-old age group. So they're driving continued transmission and continued spread. We still do have infections among those youngest age children, but they're not likely the drivers of spread as much as those teenagers and young adolescents. So some of the things we've learned about COVID in children over time: children are less likely to be infected. There have been some studies that look at COVID within the same household. And when there's an infected individual, children are 44% less likely to be infected than adults who's exposed. Children are fortunately less likely to experience severe disease as long as they don't have an underlying medical condition. Those children have a greater risk for severe illness. Children, when they are infected, oftentimes are less likely to show symptoms. And when they do show symptoms, they're often milder and more cold-like with fever and cough. Interestingly, children have higher levels of virus in their nasal pharyngeal and oral pharyngeal passages, but it appears that they are less likely to transmit that virus effectively than adults. And we'll talk in a second or two about some possible theories for that. There are some interesting differences, though, by different age group, as I mentioned earlier. And those 12 to 17-year-olds have twice the infection rate of 5 to 11-year-olds. And here's that same point in a slide. So that top line are 12 to 17-year-olds, the rates of infection, sorry. The bottom line is the 5 to 11-year-olds. So double the rate of infection among the teens to the elementary school age children. We'll skip that one. So a couple of the theories. So those younger children, even though they have higher amounts of virus, they have lower infection rates. So a couple of thoughts is that younger children physiologically might have fewer of the receptors that lead to the virus getting into our cells than older children and adults. And that could be one physiologic explanation. And it could be that they've also more often been exposed to other viruses in the coronavirus family that cause the common cold. that confer a bit of partial immunity that might give them some degree of protection from the SARS-CoV-2 virus. I mean, those are a couple possible physiologic explanations. And I think, as we'll get into later, it's also possible that there's just behavioral differences. 5 to 11-year-olds are often much more compliant with some of our public health protective measures than that older age group. So there are certain risk factors that increase the likelihood that children are, when they're infected, have more severe illness. Certainly babies under age 1 are at greater risk for severe illness. Children with moderate to severe or uncontrolled asthma, diabetes, certain metabolic or genetic conditions, including sickle cell disease, certainly infants who are immunosuppressed or have had heart disease since birth. These are all more medically fragile children who, when infected, have a greater risk for severe outcome. And you might have heard, especially last summer, a lot of attention to this inflammatory syndrome, multi-system inflammatory syndrome, or MIS-C. And this is a complication that appears to be related to prior COVID infection that shows up 3 to 6 weeks after a child has been infected. In some cases, it's a child who's been infected with no symptoms. Fortunately, while this is a concerning syndrome, it has been shown to be very rare. So among infants, infants who are born to women with the virus are more likely to be delivered preterm. And then, although infections in infants are rare, children under the age of 1 are definitely at higher risk for severe illness than older children. And most of them have mild cold-like symptoms and recover within 2 weeks, fortunately. And I think I will pause there, Mark, and turn it back to you.
You do, because I mean, thank you so much. It's always really interesting to sort of see those figures, and things always strike me, particularly sort of like the pattern that things are as high now as they almost were last March, when we were really sort of had a lot more perhaps anxiety. But when it comes to kids, and I think I've mentioned this to you before, Brad, I receive questions in from different staff across our network. And so what I took those questions this time around and sort of split them into areas. And so we're going to look at the different age groups of kids, from preschoolers to middle schoolers and high schoolers. But before we sort of get there, I just wanted to touch on some of those rates, because someone had asked a question in relation to kids and COVID that, as you mentioned yourself, the rates are lower. They tend not to get as sick. So is it really necessary to develop and vaccinate these kids? Is the question, with the risks that come with vaccinations or concerns that people have?
Yes, I think, and we can get into the concepts of herd immunity and what it takes to return to normal. It's likely we're going to reach a point where we have some amount of virus that continues to circulate across the globe. And, hopefully we're going to get to a point where we can have some degree of normalcy, where we can have a return to social gatherings, maybe not have to distance and mask all the time, although we might have certain settings that are high risk where we need to do that. And if we have a future state where we only vaccinate adults and don't vaccinate children, I think it greatly increases the likelihood that we have virus circulating that threatens our most vulnerable in society, because children will be a reservoir for that virus to continue to be fueled and move along and continue to impact us. So I think ultimately to get to a point that feels much more like pre-pandemic, we are going to need a vaccine that's been demonstrated to be effective and safe among children.
Our last session was around vaccinations and sort of reassuring people who are listening in that the vaccines are safe and they've been tested. And so we're seeing more vaccines rolled out, Johnson & Johnson, the one shot, and Moderna, Pfizer. It's like, if they're considered safe for adults, why aren't they for kids? Like, I'm not a scientist. I'm just really curious if you would have an answer.
That's a great question. So children, when it comes to our immune system and our response to infectious diseases, aren't just miniature adults. And we really do need to, after now demonstrating that these vaccines are efficacious and safe in adults, we do now need to go demonstrate that they work just as effectively in children, that they're just as safe, in order to feel comfortable vaccinating those younger ages. And so the companies, the Pfizer and Moderna and Johnson & Johnson in the US are already all actively enrolling children 12 years and older in their clinical trials, so that we can hopefully in the coming months learn whether or not we see the same level of effectiveness and safety. And one of the companies is actually Moderna, also begun enrolling children from age of 6 months to 12 years of age. And part of what they'll be testing, in addition to looking at the efficacy and the safety and how long we have a level of protection, is also the dosing. We need to also consider whether or not the dosing might be at lower levels for children in order to be efficacious and safe.
Great. Is it, you almost sort of answered a sort of a follow-up question that someone had, sort of about sort of a rollout. So kids vaccine, if you got a crystal ball, when would you say we might start seeing, say, for that 12 to 18-year-old group?
So the FDA is requiring the manufacturers to have, on average, 2 months of follow-up data after somebody has been fully vaccinated in order to look at the efficacy and safety. And so I think each of the companies now are still in the midst of enrolling children 12 years and older. And so, when they reach their enrollment goals, then they'll need a couple of months. So I think it's certainly possible that some of the companies could be going to FDA to get approval to vaccinate children 12 and older by the end of the summer. I think that that's probably the earliest, but I don't think it's reasonable to expect that we'll be vaccinating children under the age of 12 until probably into 2022. Yeah,
and it seems, because I think what you sort of said before, that it's sort of a rollout like that to me seems to make sense. You focus on this group that have a higher rate of cases of COVID than the group under 12. And it leads me a little bit to start talking about sort of schools in a way. If you have a preschool setting, so kids basically 5 and below, after the first little wave here in New York, they reopened. And yet our schools struggled to stay open, and some have remained closed throughout this whole process. Is there a reason why, like, preschools were able to open? Were they safe? And if so, how?
Yeah, childcare facilities in the state of Rhode Island never closed, is my understanding. And, I think practically speaking, they remained open because we had essential workers who needed to have a childcare solution. And it just so turns out that we really didn't see many outbreaks in that setting. And I think it's a harbinger for the experience that we then later saw in-person school instruction beginning in the fall of 2020. And I think it's because those younger children are more often compliant with the different protective measures that we need to implement in that in-person instruction setting or childcare setting. And I think that there truly is a physiologic difference in that when they are exposed, they're less likely to be infected. And when they're infected, they're less likely to transmit to others.
Yeah, because I did, it's interesting because, and I'm quite sure that's the answers are behind this in a way, but I think of my kids when they were 2 and 3, and the idea of social distancing with that age group, or having them to continually wear masks, not to share a toy, trying to even explain the rationale. One of the questions we'd had is, how do you do that? Or should you be sort of enforcing that?
Well, it's certainly difficult to get a toddler to do certain things that you can get an older age child to do. But, some of those strategies, like de-densifying a room, or, not having objects be shared, it's the setting is largely controlled by the instructor or the childcare provider. And so how many children you put in a classroom and whether or not they even have objects that they can share, for example, are greatly in control. And so it is, in a way, a lot easier to assure compliance with some things for children of that age group. Also, I would just say that while we don't recommend masks for children under the age of 2, we certainly see that toddlers and young children, once they learn to use masks, and if they're ones that are properly fit, they have high levels of compliance with mask use as well. It's just a matter of another opportunity to instruct children of that age group in what behavior we're looking for.
Can I ask you, just sort of following on from that a little bit, this was a question someone asked me last week and I really didn't know the answer. For those kids who are in preschool, hand sanitizers, I just assumed it was safe, but is it, do we know, or are they recommending other products that you've heard of, or?
Well, we certainly want to encourage good hand washing. I mean, that's certainly, hand sanitizer never replaces good hand washing. Yes, I think it's completely safe to use hand sanitizer in younger age children. I mean, you just want to make sure that you secure that hand sanitizer so that they're not ingesting it or touching their mouth with it. But to again teach proper use. I think children at an early age can be relied upon to use hand sanitizer safely.
Great, because the other thing I think, just when you're talking about the socialization component, something that I saw here more than ever was the use of outdoor space, and with these childcare facilities, even late into the winter, to spend as much time outside as possible. And someone had asked a question in relation to sort of safety around eating and snack time, and I'm assuming the same thing would go. The outdoors is the best possible way if the weather permits.
Yeah, I'm going to pull up a slide here if you don't mind, because I think we do often get a lot of questions about what does safe meal service mean, and you're absolutely right. First, if you have the ability to have students and staff eat outdoors, if climate permits it, we have a nice beautiful spring day here in the New York area. Colleagues around the country might have different climate, but that's absolutely something that we want to do. Where possible, we want to have touchless methods for counting meals in schools. Obviously when somebody eats or drinks, they need to not use their mask, but we want to be really efficient about that and have them resume mask use as soon as they're done with their meal. Where possible, we want to serve grab and go and not have meal service. Do things like put physical barriers in place and use disposable items. But ventilation is really important, and then there's a lot of other strategies to assure that there's safe meal service really at any age of school instruction.
That's good. Before I move on, anyway, there was a question in the chat box, and sort of as we're going along, and it relates back to sort of the safety of vaccinations. And I'm not sure if you would know the answer to this off the top of your head, but the latest on sort of pregnant women and the safety of receiving the vaccination. Have you heard anything?
So the recommendation is that pregnant women should just have a discussion with their provider. That pregnant women were not enrolled in the initial clinical trials. And so there's really a lack of data on efficacy and safety. I will say, though, that this was a topic of a lot of discussion by the Advisory Committee on Immunization Practices. Certainly most clinicians would probably recommend that women who are pregnant get the vaccine, because there's no reason to believe it won't be just as effective and safe among them, and they are at increased risk. But I think, as opposed to issuing a blanket recommendation, currently it's recommended that women who are pregnant consult with their healthcare provider, and then, who will most likely be encouraging them to get vaccinated.
Right. So moving on a little bit to sort of the elementary schools and sort of middle schools and stuff. And actually, I'll just encourage people again, if you have questions, as I'm chatting here with Brad, just to sort of submit them into the chat box. We'll either collect some for the end, or if we can sort of incorporate them as we go along. So the more the merrier. That's the whole purpose, is to answer your questions. But we've seen New York City schools open, close, open again. And obviously it sort of responds a little bit to the number of cases in the community and at times certain parts of the city. But one thing that was part of reopening was the requirement of schools to test a percentage of kids for COVID. do schools have the right? I'm just curious, the right to actually ask someone to do a COVID test, and what if they refuse?
Well, testing is certainly a strategy that I think we've learned since last fall, both in the college setting and the high school setting, is an additional tool in the tool belt that can help identify asymptomatic infections that and get those individuals properly isolated and their contacts quarantined so that we can stop transmission in school and college settings. And so certainly we've learned a lot that now puts us in a position where we recommend testing. And I'll also just mention that, you know, the types of tests, including these antigen or rapid tests, are ones that we also think are appropriate to use in a school setting, especially if they're part of an ongoing program for testing. You know, whether or not you actually mandate this, I think is a little bit more complicated discussion. I think we would always want to offer a test to individuals and create incentives before we ever consider a mandate, whether that is a test, a vaccine, or another intervention. You know, and I think it also depends on the current circumstances. If there's low levels of infection, you know, that obviously it would be harder to justify or rationalize a mandate for a test as opposed to an outbreak situation where, you know, you're having difficulty controlling the situation.
So interesting. But the other thing that's been a big drive sort of in the New York City area has been around teachers. And I know it's been controversial across the country about should they be prioritized for vaccinations? Should they be on the wait list? And my understanding, most states now have opened up vaccinations to teachers. So if we get to a stage that our teachers are all vaccinated, people return to in-person school, someone had asked, what will it look like? Like, will we be back to no masks? Will there be a need to social distance? Can kids eat in the lunchroom again? Can we, like my son actually went back today for his first half day, but he had to bring his computer and work in the classroom on his computer like he was at home. So like, what sort of normality can people expect?
Yeah, those are great questions that we get commonly. And I want to start by just reviewing some of the current recommendations that the CDC issued now. I think it's actually 2 weeks ago on what fully vaccinated individuals can do. You know, what are the new privileges that they can undertake. So first, they can now, once you're fully vaccinated, which is 2 weeks after your last dose. And so if you're in a 2-dose series, it's 2 weeks after the second dose. If it's the single dose J&J, it's 2 weeks after that first dose. You can now, according to the CDC, visit with other people who are fully vaccinated indoors without masks or physical distancing. And you can also visit with unvaccinated people as long as they're just people in a single household and that whole household has people who are at low risk for severe COVID. And you can do that without wearing a mask or physically distancing. People who have been vaccinated also, if they've been exposed, they can refrain from quarantining and refrain from testing so long as they don't develop symptoms. You know, so I think what we're finding here is good evidence that individuals who are fully vaccinated are protected from infection. But there's still a little bit of uncertainty about whether or not, if we've been vaccinated, could we still be carriers of the virus and transmit to others? You know, we're getting more and more evidence from Israel and some of the manufacturers that, like with other infectious diseases, once we're vaccinated, we're also not effective carriers. But we didn't know that initially upon approval. And so we want to just be really sure that people who are fully vaccinated, before we stand down all those protective behaviors, you know, be sure that they weren't potentially going to be facilitating transmission. And let me just show you now. So fully vaccinated individuals should still take precautions in public, wearing a mask, physically distancing. When they're meeting with other unvaccinated people, especially those who are at increased risk, they should wear masks and physically distance. They should wear masks, maintain physical distance, and practice other measures, especially when they're meeting with people who are from multiple households. we still want to avoid larger in-person gatherings. We still want people to be tested if they experience symptoms. We don't yet have long-term data on how long these vaccines are going to be protective, and how long our immune levels, our antibody levels stay high. So continue to follow guidance from our employers on things like use of personal protective equipment and any of those travel restrictions. So I think we're certainly hopeful that we'll begin to get the data that show that for longer periods of time, maybe 6, 9, even 12 months, we have levels of protection, and we have evidence that we are no longer effective at transmitting the virus. That might get us to a situation where once we have high levels of vaccination, or we have individuals who are vaccinated, maybe we can resume more of these protective measures, and resume some of these gatherings and other things that we are pre-pandemic that we want to be able to get back to.
So it's interesting because, I've been very hopeful with the vaccinations being rolled out. And it wasn't until someone raised this question about schools it even dawned on me. I just had this assumption that the teachers would be vaccinated, once kids get vaccinated, and everyone would be maskless and would really return back to a normality. And I think it's still a little bit sort of depressing. One thing I've learned, I suppose, over the year is things related to COVID change rapidly. So, and I've sort of seen that, and so maybe hopefully we'll learn more, and we will be able to not have to wear masks, or for kids in particular, into the schools.
Yeah. Well, Mark, maybe we can talk about herd immunity a little bit, because I think that this is a concept that some might be misunderstanding. It's not like we have this number of 70 to 80%. And as soon as we reach it, the alarm bells go off, the ticker tapes come down, and we can all resume pre-pandemic behaviors. Herd immunity is a concept that I think of as being much more hyper-local. What's the level of immune protection in that nursing home where my older adult loved one lives? What's the herd immunity in my child's school? What's the herd immunity at that wedding where I want to go to this summer with people who are going to be coming from all over? And it's unlikely, unfortunately, that I think we're going to get to the point where the answer to each of those different settings is that we have very high levels of protection. And I think that's because we will not be vaccinating children for some time. And so if that number hypothetically is 70%, that magic number for herd immunity, if we can't vaccinate children, that means we need to have a much higher level of vaccination in adults. It's actually in the range of 85% in order to reach herd immunity protection. And so I unfortunately worry that herd immunity is going to be a little bit more evasive for some time until we can vaccinate children, until we have evidence that shows that the duration of protection from the vaccine is longer. And so regrettably, I think, well, we're going to have to maintain some of these protective behaviors. It might be that we can relax mask use in certain settings. It might be that our distancing, again, in certain lower risk settings can be relaxed, but I think that it'll be a slower return to normalcy.
Yeah, it's an interesting point, and I think there's something like that uncertainty that remains about those who got vaccinated. How long is that vaccination good for? And then knowing when yours to sort of run out, and how often to get a top up. And I think someone else pointed out, it might have been Kavita, that a lot of Southeast Asian stuff have worn masks for years and years before this, and it's something that's just become part of our culture over there. And perhaps I think even myself, I drive sometimes and I don't blink and think people look odd wearing masks. I sort of sometimes admiring their mask, going, "Oh, that's an interesting design they got." So,
residents of countries in Southeast Asia wear masks during different seasons when the respiratory viruses are circulating, or when environmental allergens or other pollution levels are higher. So I think that we have not been used to mask use here in the United States. I do think that we will have some level of mask use that persists beyond the pandemic, especially in high-risk settings.
Yeah. Even if you mentioned it sort of under other sort of things like allergies and stuff like that, if people are out walking, it's now more acceptable to be seen. You're not like the odd stranger in a mask. It's more acceptable to be seen. But just back to the schools and the buildings in a way. So, there's been so much sort of debate. So get the teachers vaccinated, incredibly important. But, in some school districts, even when that has occurred, people are like, these buildings are old. In New York public schools are sort of renowned for that the ventilation systems aren't great. And could you talk me through that? Because I don't fully understand it in a way, like why people get so caught up on what that ventilation means. And any sort of sense that you have of sort of schools or businesses even, and the importance of ventilation?
Yes, let me pull up another slide here, Mark. So first of all, we like to refer to this triangle of non-pharmaceutical interventions because they work in tandem with each other. The quality of the ventilation of the setting, the type of mask use that we recommend, and the type of distancing. And so I think what we really try to emphasize is that there's certain situations where ventilation is optimal. If you're outdoors, that's a situation where you've got great ventilation, the respiratory droplets are going to move quickly to the ground, and the risk is lower for transmission or that you inhale those respiratory droplets. And so because of that, the distancing can probably be closer together. The mask use can be one of our options that have a lower level of protection. But conversely, if the ventilation is not optimal or less optimal because we're indoors, it's a smaller room that has less or fewer air exchanges, that then would be a situation where we want to optimize distancing and make sure that we have 6 feet or more and have the highest level of mask use that we can. If we're going to be in a bus or in a car with somebody for a long period of time, that would be when we would want to have the highest level of mask use, maybe even double masking. And so I guess first I want to make the point here that consider these interventions in working together. But then when you look at ventilation, as we've talked about before, the best ventilation is being outdoors, just maximizing the outdoor air. If that's not an option, we want to increase the amount of air that's circulating, so that there's a lot of flow. We're getting a lot of air from the outdoors. And an additional type of protection is through filtration. Some of these filtrations of different levels of standard and protection, HEPA and up to MERV 13. A lot of our buildings, where possible, have tried to make changes to increase the level of filtration. Some just don't have the ability because they're limited by the engineering of the current HVAC system or by funding. And so it's not that there's a minimum level of filtration or ventilation that's acceptable. It's just that we want to always work with these interventions to do the best that we can to lower risk and enhance the level of protection. And so, if there's a situation where you can have outdoor air or you can open the doors and windows, you should do that. But if not, don't fret. Don't stop in-person classes. We want to continue in-person school. It's just then that might be a setting where you want to maximize distance, reduce the numbers of children, and optimize mask use.
With that, to reduce the number of kids and stuff, and I think they call it, I think our school district, it's hybrid. So people go in 2 days a week and 2 days. Is that what you're sort of alluding to? And is there a max number for a classroom, or is that just going to be very much about obviously the size of the classroom and ventilation?
Yeah, there's no magic number. I mean, it does vary by the room that children are meeting in. There's lots of different strategies that schools have implemented successfully for increasing distancing and de-densifying, if you will. My daughters have a hybrid model of instruction where they're in person 2 days a week so that they can have smaller counts of children in each school. You can do things like have traffic patterns throughout the school where children are less likely to be in close contact with each other's. That's especially important in meals or other higher risk activities like phys ed. And so there's no magic number. We want to increase the distance between children. We can get into it, but there's actually emerging evidence to show that even that 6 foot minimum threshold, which had been the metric of importance before, CDC recently now has changed that to be 3 feet based on some emerging evidence.
It's, you know, it's funny, something like that, and I'm not going to sort of be the same, because I heard that too on Friday. And I see it, and I could just see that sort of like, oh, there's a big push to open schools again and open stuff up. Well, by the way, you don't need to be 6 feet apart, 3 feet apart is going to be fine. That I'm, you know, just, it's sometimes I'm wondering if people might be listening in going like, yeah, the time is really convenient. Like you really want to open society, and all of a sudden 3 feet is good enough.
Yes. So let's talk about that a little bit. I mean, I think there's a couple things, if I could just unpack that. You know, first, I think there's this iterative process of discovery in this pandemic that I think people sometimes misinterpret as uncertainty or flip-flopping, you know, when really this is a pathogen we haven't experienced before in the globe. And so we do have this process of discovery and study that prompts us to make changes based on emerging evidence. And so I think that is often the case what is happening. In the case of the science behind 3 and 6 feet, you know, I just want to go into this just for a little bit. So pre-COVID pandemic, there were some planning assumptions when those of us in public health talked about pandemic plans. We talked about influenza. Mm-hmm. And there were some studies that were done more than a decade ago to look and see what the distance is that we typically would see the respiratory droplets that contain the influenza virus in this case. And what this one study showed is that the largest molecules, which are the white portion of these bars, were typically found within 1 foot of an infected individual or 3 feet, but very rarely 6 feet. The smaller particles, which are the ones that would typically be associated with airborne spread, were mostly found within 1 foot, less 3 feet, and a little bit smaller 6 feet. So what CDC and other health organizations did at the time when coming up with this idea of distancing was take this data showing that most particles were found within 3 feet and doubled it to 6 feet. So we have a little bit of protective margin, if you will, in there. So when we look at the COVID experience, though, there was a new study here in Massachusetts where school districts actually had the discretion to choose whether or not they were going to require 3 feet of distancing between students before reopening or 6 feet. And so we had a nice natural study here that investigators then evaluated. And they found that the rate of COVID among staff, when they compared the blue line, which are the districts that use the 3 feet distance, versus the gray line, which is the 6 feet of distance, there was no difference in staff infection rates. And there was similarly no difference in student infection rates between the districts that had 3 feet of distance or 6 feet policy. So that was sort of an ecological study, we would call it, that gave us some evidence that 3 feet maybe would not be a concern. And so, you know, what we're seeing now with CDC making that shift in policy is that now, based on this and other evidence, we really feel that at the elementary school level, primarily, we're comfortable moving to 3 feet, and that inability to keep 6 feet of distance at the elementary level shouldn't preclude a school from opening. And I think part of what's contributing to that is that low rate of infection among that younger elementary age group. If you think back to one of my first slides, the 5 to 11-year-olds, you know, while they have more virus in their body, they are less likely to be infected. They're less likely to transmit. And so I think, you know, we're more comfortable now with a closer distance in in-person instruction.
Thank you. That was all really incredibly interesting and certainly answered the question for me. And I think something that you said there, Brad, that is so true. Is that this is uncharted territory in many ways. And so when someone does an about turn or goes, you know what, we had recommended this, now we're recommending that, there isn't necessarily an ulterior motive. It's just that we have learned more about this virus over the course of time. And to bear that in mind, because sometimes, you know, myself, I'm a little bit like, oh, I don't know, it's government and trying to control things. So I think it's really interesting and something that we should be constantly reminding ourselves of. Somewhere where there isn't social distance, but was a question that someone asked, was school buses. Like you see them driving around the city and stuff. How safe is it to put the kids back on the buses?
Well, we haven't seen a lot of evidence of transmission occurring in transportation to school. We certainly would want there to be optimal mask use. We want to do whatever we can to shorten the distance of travel, optimize ventilation by doing things like cracking windows, and we want to have distancing on buses. It's not that we want children to sit side by side. We would certainly want there to be 3 to 6 feet of distance between children. So there's a way to do transportation that's reduces the risk of transmission. And I think by and large, schools that have opened have been able to do that.
And then another one that comes up with some extracurricular sports activities. Obviously, if they're outside, we're saying things are safer and stuff, but in the fall, my son was wearing a mask playing soccer. What's the latest sort of on sports?
Yes, so I want to find a slide here to tell a little story about colleges, which I think is helpful here. But I want to tell you that by and large, I think athletics outdoors have been found to be safe. It's great ventilation. There is some evidence that there has been transmission at athletic events indoors. So there was a large wrestling tournament at a southern state where there was not good mask use. And there was a hockey game and certainly hockey in northeastern states where it was sort of a high respiratory activity indoors, not always good mask use, not great ventilation. So transmission can definitely occur indoors. Things like a squash or a racquetball court would be high risk. So those are ones that we probably are not comfortable yet resuming. But outdoor physical education and athletics has really been found to be pretty safe. We don't see a lot of transmission in competition. But I do want to talk a little bit about this study here. There was a publication over the summer in the Centers for Disease Control has their MMWR. And this is from a university in the Chicago area that had an outbreak among the men and women's varsity soccer teams. So students came back in June. They were required to have 2 negative tests before they began participating in July. So they had effectively created a bubble, if you will, within these teams. But in August, a player on the men's soccer team reported symptoms to their coaches. And they ultimately ended up testing the 45 members of both teams and found that 17 men and women were ultimately found to have COVID. And when they went back and looked at the behaviors among these students, the initial case patient was reported that he had attended a birthday party. There had been a non-approved co-ed soccer match between the teams, and there were other social gatherings during the 14 days before his onset of symptoms. In fact, there were a total of 18 social gatherings that preceded that outbreak, and physical distancing and mask use were not optimal. In fact, they were probably not existent. Ultimately, cases were 10 times more likely to have lived in shared housing with teammates, more likely to have attended that birthday party. And so I think, what we learned from this study and also just from colleges' return to instruction in the fall was that colleges are an especially high-risk setting for outbreaks because of social gatherings, congregate living, and mask use and physical distancing and protective measures are not often followed. And I think this is sometimes what's the greatest risk among athletic teams. It's what happens off the field than more so than what happens on the field. I think we've found a way to be protected in that outdoor field of competition. But when those social networks of athletic teams get together on the weekends and evenings and feel a sense of complacency because they're among their comrades, they're less likely to wear masks and they're less likely to distance. And I think that's where we need to really be vigilant, that even when we're among those close social networks, we need to limit our gatherings. And absolutely, if we're going to gather, do it in a ventilated setting, wear masks and distance.
I'm going to jump ahead a little bit because I did have a question sort of more later. Someone had asked about social behaviors, and it is, I'm just thinking of those teenagers because I see them sort of around where I live and stuff. Your teenage years are drawn to go to parties, they're going to gathering and stuff. How do we, like, what advice like maybe you might have for parents about how to parent a teenager during a pandemic, like how to ensure socially they're connecting with folks, but at the same time sort of remaining safe because, as you say, behavioral wise, they could be sort of the biggest spreaders in a way.
Yeah, I'm a firm believer in harm reduction, and I think that's something your audience might be familiar with based on their backgrounds. But whether we're talking about substance use or whether we're talking about other behaviors, I think we need to be realistic in expecting that these behaviors are going to occur. We are not going to prevent our adolescents, our college-age kids from gathering. And maybe what we need to really instruct them is if they're going to gather, and we would prefer that they don't, but if they're going to, here are some ways that they can reduce risk. They can gather in smaller numbers. They can gather in more ventilated settings, outdoors or with windows open. They can absolutely wear masks or even double mask. Those are things, those are behaviors that we need to destigmatize and normalize, so that we can find ways to still have parties and gather, but do it more safely using harm reduction strategies.
Yeah, I mean, it's such an intrigue because I think the last couple of questions I have in a couple of minutes are really around some of the sort of impact that this is having mentally on our young folks, because it's such a change to the norms that you even see in a movie or something like that. And it's hard to break those sort of behaviors. But before I do, I have sort of one last sort of question that someone had about schools. If there's an outbreak at, like, say, my son's school, are all kids going to be required to quarantine? Has there been guidance on that? And there's a follow-up to it, which I'll just throw in straight away. If that kid who's perhaps tested positive or is quarantined has a sibling who's in a different school, like, does it just become a ripple effect and knock on? Like, how are sort of schools managing that? Do you know?
So schools that have been meeting in person have become experts, unfortunately, on contact tracing and on these containment measures, we call them, which is to test and isolate and quarantine. What does happen when we learn of new cases is that we need to find out who are those close contacts, whether it's someone who shared a room or a bus. So certainly schools are working very effectively with their local health departments to do some contact investigations. And oftentimes there's a need to quarantine individuals who were potentially, had 15 minutes of contact or more within 6 feet or less. So certainly my school, on a daily basis, I get a text that has the number of new cases, the number of individuals who are quarantined. I will say that over time, I think as a indicator of success at their ability to implement a really solid plan for in-person instruction, we often don't have a lot of individuals who are quarantined. We learn about people who are sick and they stayed home, and so they didn't expose individuals, or they're people who were diagnosed while they were already under quarantine, and so there weren't exposures. And so I think it's unfortunately become part of the normal process for business for K-12 schools and colleges to rapidly find people who are positive, get them isolated, get contacts quarantined so that we can stop transmission from occurring. And what we've learned through a lot of that contact tracing activity is that there hasn't been a lot of in-person transmission in school settings. Most often when we've seen in my district and the data from the experience in districts across the country, that transmission most often happens in those social gatherings and outside of school setting as opposed to the in-person instruction setting.
Mm-hmm. Just before we move on, the slide deck, will you be able to share some of these slides with folks?
Absolutely.
We can send those out after, because there is someone that asked a little bit more about the 3 foot, and they may have missed that little earlier part of the discussion. That and like this move over to the recommendation of free feed and will it be safe? And Brad shared some slides which indicated that like it would, and sort of explained through why. I think this has also been recorded, which will be on our YouTube channel. You'll be able to hear a little bit more about that discussion we had previously. So you'd mentioned your kids being hybrid, mine are too. There's a lot of technology that they're doing a lot of work from computers. We're very privileged and fortunate that they have those devices. There's a lot of kids, and someone had asked me a question about sort of like this growing evidence of negative impact of COVID, remote learning on children of color, giving the varying preference, access, and overall disparities for online education, learning amongst white, Black, Latinx, and Asian families and communities. And it's just wondering, like the question is like, is there any recommendations that you would have to support or advocate for those children who perhaps are in more disadvantaged communities and maybe slipping? Someone told me there's a lot of kids in parts of New York City who haven't gone to school at all, and sort of been lost through the cracks of the Department of Education. And do you know if there's any plans on how to support those communities?
Well, you know, I think that there's clear evidence that from an educational perspective and social perspective and others, it's not optimal to maintain remote only or hybrid instruction. So where we have evidence, you know, I talked about that iterative process of discovery, you know, where we learn, like we have, that in-person instruction for elementary children in particular is lower risk. You know, that might be a situation where I know some districts are having discussions about bringing their kindergartners back full time. And I think, you know, with respect to communities of color who have not had the same level of access for remote instruction, and honestly, I'm not sure that any population or remote instruction is as good as in-person instruction. You know, we want to constantly be looking to see where we can push forward and resume in-person instruction safely.
Yeah, I agree. I mean, I think it's a little part of what you said there. There will be outbreaks, and I think we'll get to a stage where people are sort of switching a little bit back and forth. But I think everyone is sort of striving towards that opportunity, and it's not just in the US. I mean, obviously I'm from Ireland, and I see it across Europe. Israel was the same when they started to reopen the schools, and it's been a priority sort of around the world. And part of it obviously is the academics, but the other part is something that came up from a number of questions is around socialization and the importance of that for our sort of our growing child, their development, and particularly around mental health. And I have read, and I'm sure you have seen reports too, of unfortunately increase in anxiety, depression, suicidal attempts. I read one about eating disorders and these impacts that are having on our teenagers and kids younger. And I'm just wondering, like, is there, what you've heard about that? Some people talk to us that say there's a mental health tsunami going to hit us once, even after COVID sort of subsides. But the second part, and I'm not sure your depth in behavioral health, but it's like, is there signs you would suggest for people to sort of like to look at that might trigger them to want to get help, or see if they see something, or if you're a caseworker listening to this, how could you support a parent who's perhaps concerned about a child?
Yeah, this has obviously been very isolating time, and you know we by nature are social creatures, right? We really, for the most part, do rely upon those social interactions, and in children especially. That there is unfortunately really compelling evidence to show that there has been a whole mental health impact of COVID-19. You know, that's you know, should be just as concerning as the physical harm. Pandemic has resulted in increased levels of adverse mental health conditions, substance abuse, suicidal ideation. There was some work done by CDC that found that 40% of US adults reported struggling with mental health or substance use in last summer in June. and a 3- or 4-fold increase in the reported prevalence of anxiety and depression over the prevalence from 2019. So those are huge increases. And we're talking about a mental health system that was already pretty strapped and overwhelmed. And to add that kind of additional caseload and need is tremendous. And so we've definitely seen that the social isolation has really disrupted all of our daily routines. But I think children are especially vulnerable to the negative repercussions of that. And certainly, children need that children learn a lot more than just the academics at school, and that social interaction, and other loss from having that full-time in-person instruction definitely poses this additional potential risk for the mental well-being of children. As for the signs and symptoms, I'm definitely not a mental health expert, but I think they're largely a lot of the same signs that you would typically see for anxiety and depression. The challenge here is how do you perform that assessment for a child that you're not seeing at all, or a child that you're seeing more rarely, or that you have you see them now with masks. And I think teachers obviously have a lot more that they're having to juggle and balance with maintaining compliance with COVID protections. So, I think really just checking in on those children, certainly who already had pre-existing mental health conditions, but also ones who just appear to be really struggling and with behaviors that could be early indicators of anxiety and depression in particular.
I mean, I can tell you I'm not sure how old your kids are, but I have a 13-year-old and a 12-year-old. And the weather's getting nicer now. We've been pushing them to meet someone outside. And back to what you said in relation to those teenagers, it's not to get together with a big group of 10 people, but reach out to one person sort of each week and have a little date at the park, buy a Starbucks and sit outside or just hang out on a wall, as I used to do as a kid. We used to just sort of sit and just talk. And I think we've tried to do that because I think we're trying to get them out of the games, sitting inside and because I think there's a question that sort of came up a couple of times from people is, how do you distinguish between a kid maybe becoming more depressed and a kid who's just playing video games because there's nothing else to do,
Right. I think there's this concept of your protective bubble too. I think, and I agree, trying to have small gatherings with one or maybe two friends outdoors is and especially being distanced is a great solution. Taking advantage now that the weather's improving of the outdoors. Frankly, I think we were really creative. And the colleges I work with were really creative in the winter as far as winter sports and winter activities. So we definitely want to encourage those. But this concept of a protective bubble, I think, many of us have found that one family or the one childhood friend for our children. My children are similar age, who we, have worked with that family. We know that they are similarly restricting their movements. And so the risk is really low because we know we've just expanded our bubble from being our one household to including maybe one or two other households.
But it comes with so again, this is back to learning in a year. This time last year, I remember at the parks, they took down the basketball nets, they took down all the swings and literally taped around them so they do not enter. But then I walked by a park yesterday and it's packed. It's a beautiful spring day. And there's parents and there's kids and stuff like that. And back to your bubble, is that safe? Again, I know we've talked about outside, but I was talking there was 50 kids on that playground crawling out of stuff. And that's a sort of question I have, how safe are we? Is it safe to go there?
Well, early in the pandemic, we certainly were more concerned with outdoor activities. We were more concerned with surfaces too, and potentially getting transmission from surfaces. I think now we should be more comfortable with those outdoor activities. Now, I would prefer that we have more distance and we encourage mask use. but I think outdoor activities are things that we should be encouraging. And I know, some of the colleges I've worked with have done things like put fire pits up and have outdoor games that we want to keep kids from gathering indoors. And sometimes that means finding creative ways to get them to gather more safely outdoors.
Right. And I think the other, obviously, the underlying thing is if there's a concern, I think as a parent, you know it. And if you're a worker and working with someone who is a parent, parents often have a gut feeling when there's something not right with their child or their behavior has differentiated a little bit. They, maybe eating less or have become more withdrawn. And that's time to seek help. That's what I always, as a mental health clinician myself, would say. And unfortunately, I'm hearing it is getting more difficult to get into, particularly with children, to a child therapist and stuff. But our schools have social workers, they have therapists associated with them. There are children's clinics, and I do encourage friends of mine and people that I work with who are working with frontline staff or with members in our agencies is if they suspect something, seek out help. There's no harm in getting an assessment. So, can I
definitely agree?
I just wanted to remind people the chat box is there because I know I got these wonderful questions all submitted to me from folks, but if you're in the room, it'd be great to hear from you as well. I just wanted to move Brad over to sort of a last thing, and some of it is maybe back to that part with the kids and the parents, or even sometimes a little bit the teachers, but it's different behaviors. And I think part of it is like the adult behavior versus the kids' behavior. And I think we as an adult are often very quick to say, oh, well, the kids, they'll have their masks off, they won't be abiding by the rules. But I've heard that's not necessarily always the case. I think sometimes the parents are worse.
I think what we've learned from in-person instruction is that children are very good at maintaining behaviors, especially when they're younger ages and under supervision. I think that the large portion of new cases that are occurring, as I mentioned, there are among that 18 to 24 and 24 and older population. I think it's the young adults in particular that unfortunately are not having high levels of these protective behaviors. Mm-hmm. And I think that's certainly contributing to the continued surges that we've seen over time is the need to have social gatherings around the holidays and to cluster in bars without masks and without distancing. I mean, certainly it's the adult behaviors that have been more concerning, in my opinion, than the childhood ones.
Yeah, I've heard just a little part you talked about sports and stuff, and we were talking about outdoor sports, and I've seen it myself on the sidelines of the kids' soccer games. The parents are huddled up with their coffees and masks down and stuff like that. And so we're very conscious on protecting the players and making it a safe game. But the spectators are the ones we don't necessarily have control. I coach the team, but they kind of could be the ones who are more of the super spreaders, if you will.
Yeah, we definitely want to model these behaviors. And I think it's obviously been a long year, but now is not the time to be complacent. We've learned a lot about how protective masks are. This is a disease that requires us to be in close proximity to get infected. We're really at a critical phase here, especially with emergence of some variant strains, but the prospect of some very effective vaccines getting into people's arms. Now is not the time to give up on these protective measures, and certainly, even when we're among close friends, parents of teammates, I think sometimes that's what happens is that people get a sense of complacency around certain individuals and they feel like, oh, they can't be infected. They're a parent of my friend. Right. You need to presume that all individuals could be infected and just be in their 2 days before they develop symptoms, and just keep a distance and keep your mask on. There's nothing wrong with that.
But don't you think there's a little part where, I'm not going to blame the news media in a way, but the the messaging has shifted over the course of this pandemic to the high numbers and the high death rates per day. And yet you show me a graph that shows infection rates in New York City very similar to last spring. But because of the talk is vaccines, and yes, we need hope and stuff, there is a little part where maybe you do let your guard down because you're like, hey, we're at the end of this. Like, you know, things aren't as bad. And I think there's a complacency that can seek in there, because I think if you look at the news headlines, it doesn't feature as often the death tolls or the number of cases until they really spike again. And so when it's just a sort of a consistent high number each day, it's almost like not newsworthy.
Yeah, I think it's been a long winter. And I think that, you know, when the population sees those declining case counts coupled with the news that we have effective vaccines, I think it's really easy to just abandon that mask use and to have that those friends over that you haven't seen in a long time. You know, and I get it. I think we need to continue to be evidence-based. We need to really double down on some of these protective measures, especially for the next couple months. I think when we get to the end of May and into June, we're going to have higher levels of the population that have been vaccinated. And I think then we're going to begin to see case counts that are down to a much more acceptable level.
That's great. So I think I'll end it there, Brad. Because I think I want to end on something positive, and I think you're totally right. I'm really hopeful too, that as the numbers go up. I don't see any more questions in the chat box. So that just really leaves it to me to thank you for your knowledge and your slides, because I think I have certainly learned a lot from your responses today. And I really appreciate you taking the time to join us and to share that information with us. So we look forward to catching up again soon. And hopefully it'll be in May, where we're looking at a different time in COVID and numbers certainly decreasing, and we'll be talking about summer camps. So
I look forward to future sessions, especially if they're more celebratory than what we've had over the last year. And thanks for having me.
Thank you. And to those who joined us today, thanks so much for joining. And we will keep you informed of our next town hall session. And please submit questions to me in advance. Really appreciate them coming in. Take care and have a good afternoon.